Good afternoon. My name is Nathaniel Brooks. I'm a neurosurgeon at the University of Wisconsin in Madison, Wisconsin. And to my right here today, I have Dr. Hoon Choi. He's a neurosurgeon at the Cleveland Clinic in Fort Lauderdale, Florida, and Dr. Nick Jain, orthopedic surgeon in Southern California. Today's topic of conversation and Ask the Experts is using minimally invasive spine surgery for trauma applications. We're going to talk about an introduction as to how to use it, what kind of patients, those kinds of things. So we'll start out with a question for both of our experts. Is when did you start using minimally invasive procedures for trauma care?
Right. So when we see trauma patients, they're having the worst day of their life, and you counsel these patients on their problems, and they already have other injuries, concurrent injuries, and there's a lot of pain, and they're worried about getting out of the hospital, ambulation, and there's a lot of other things going on. So you want to select a procedure, a way to do things that minimizes pain and other things. So when I first started, as with many spine surgeons, we train on first when we learn the anatomy and the open approaches, and the natural progression is to gravitate towards minimally invasive procedures. And I think with the advent of navigation and intraoperative imaging tools available now and the instrumentation going forward, it's really allowed us to apply these principles to trauma patients more easily. So when we see the trauma patients, whether it's cervical, thoracic, lumbar, or even sacrum, the natural workflow has become, how can we minimize pain? How can we minimize infection? How can we get the patient, ambulating as early as possible out of the hospital and to participate in rehab? So that's when we started applying minimally invasive procedures and the techniques, and then it sort of grew from there.
And then Dr. Jain.
Yeah, certainly, a lot of trauma cases in the past have been large open surgeries, sometimes requiring thoracotomies and large corpectomies. And one of the nice things that we can do is we can minimize the blood loss in the approach by using lateral techniques or all posterior-based approaches. And then, especially like Dr. Choi said, really the focus on a trauma patient, especially in the acute setting, is getting them up and going and getting them as functional as possible, as fast as possible. So whether that involves adding stability in a minimally invasive way that doesn't cause more pain and limit functionality, but if we can add immediate stability to unstable structures in the spine in a percutaneous fashion, that really allows for patients to get up and moving faster and rehab not just their spine injuries, but all the other trauma that they may have in other extremities or other organs that they have to deal with, minimizing blood loss, in a possible sick patient with difficult hemodynamics.
So talk about the types of procedures that you do. I mean, for trauma. Obviously, this is not a question you can answer in one complete short sentence, but just some of the kind of things if a practitioner wanted to learn particular minimally invasive procedures and apply them to trauma, which ones would you kind of say your top three are?
Certainly, I think percutaneous stabilization for thoracolumbar trauma is a great one for unstable fractures, either with fusion, concomitant through MIS techniques, or even internal bracing without fusion. I think have a lot of application depending on the patient and the injury type to really get people moving faster and avoiding sometimes cumbersome braces, especially in patients who may not be able to tolerate one due to other injuries, body habitus, etc. So that's my number one that I kind of go to. In terms of more larger reconstruction surgery, I think lateral corpectomy for trauma is a great application to be able to remove a fractured vertebral body, restore sagittal alignment and parameters through a very minimal blood loss and minimal approach with less pain and requirement of other surgeons or teams.
And Dr. Choi?
Right, similar. So the most common things we encounter, thoracolumbar fractures and stabilizing immediately. And also, you can do lateral approaches, and once one becomes more comfortable with different tubular techniques. You can do posterior techniques, whether it's partial corpectomy and things for burst fracture that can be achieved through small tubular retractors. And also, you can really push the envelope as you go forward in this journey, and you can tackle cervical trauma. And there's different tools that you need to achieve safe surgeries in cervical spine. But there are advancements right now in cervical applications, such as you can try, there's movement for, say, MIS C1C2 that can be done, or it can be some sort of a cervicothoracic reconstruction where MIS principles can be applied. In some cases, you can do, say, midline incision, but you can still do transfascial screw insertion, and to minimize really the soft tissue dissection and to minimize that pain. And a lot of these trauma patients are young people with very robust musculature. And if you do subperiosteal dissection and you really devascularize the musculature, and they can have a lot of pain. And so MIS procedures can have a lot of benefit there too. And you're preserving the musculature, and I think people appreciate that. And for young people getting in trauma, and they also think about cosmesis and aesthetics, and that can also be addressed. And you can plan your incisions if you have navigation tools and robotic tools to exactly what you need to get the job done. And you can even plan your skin incisions on navigation. So I think that's something that's nice that's available now.
So a surgeon who's going to learn these techniques, where would you have them kind of start? I guess what it would be kind of, we maybe learn them on our own or pick them up through the course of our training, but if there's people out in practice who are starting from somewhat from scratch here, what would you suggest? I'm going to start with you, Nick.
Definitely, I mean, it depends on which technique. Certainly, lateral corpectomy is an advanced technique, and percutaneous screw fixation is a little bit more less advanced than that. But learning, it always starts, number one, you have to learn about the technique by reading about it, of course, and knowing the procedure. Many of the procedural steps will be similar. The big difference, I think, in trauma is sometimes you're dealing with anatomy that's not normal. So getting your accurate visualization with your radiographs is really key. If you have the ability to use a robotic and navigation system or I think that's a big difference and adds a lot to these trauma cases. It really helps you ensure your fixation is accurate in a setting where it'd be difficult to see otherwise, and also without having to do that subperiosteal dissection. So, learning, having that in your toolkit it's an easy way to transition into it. So using those on non-trauma cases first, and then transitioning it into trauma cases, I think is a very successful way to do that.
Yeah, I think probably the more common situation that's going to arise for people who take care of trauma is going to be things that need to be dealt with percutaneous instrumentation, and of course that is an extension from the minimally invasive interbody fusions that we often do. So that's a good starting point, kind of a basic start point. My next question kind of dovetails on this, is that in the patients who you're doing these types of procedures on, say, percutaneous instrumentation for, I'm going to give you an example, a bony chance fracture in a 25-year-old who they couldn't brace it. We couldn't brace it well, so we did percutaneous instrumentation. Are you going back and taking the instrumentation out, and if so, when?
Right. No, that's a good question. I think it's a case where patient may not necessarily be compliant or want to wear a brace, and that person wants to be back to normal, and our objective is to stabilize the fracture, let it heal, and then you want to restore the spine biomechanics to physiological status that's pre-op. So I think you also have to counsel the patient on smoking cessation and other things, but I think it's reasonable to take the instrumentation out a year later. And also, if you want to plan for the future, when you put in the instrumentation, you want to put it in a way where the screw cadence is important, even the angulation of the polyaxial heads. So when whether it's you or somebody else goes back there and take it out, you can do it through a single small incision for these. So I think thinking about the future, how the person removing the instrumentation can do it in an MIS manner. So you're not only treating the patient in an MIS manner, but also removal of the instrumentation later on can be done in an MIS manner. So that the patient can have an outpatient operation for that second part. So.
Do you do similar?
Yeah,
kind of
yeah,
case?
I agree with that. I think, for me, I'd incorporate a CT scan to really ensure fracture union before progressing on to hardware removal. But, like I said, I usually use around the 12-month time period. Sometimes as soon as 6 months, if the patient's symptomatology is improved and they have no restrictions and you have radiographic evidence of union, then I think that you could even take it out sooner. But there are some cases, you may be leaving it in and doing a MIS fusion or facet fusion through those percutaneous approaches if you feel you need that long-term added stability.
Right. Yeah, and I've done myself and seen a lot of people demonstrating doing either MIS techniques for fusion, be that interbody or mini open procedures where you do put some arthrodesis along the posterior elements and those kinds of things. So I think there's a lot of different options. So I will say to our experts here, I really appreciate your time. Unless you have any other comments, we're going to wrap this up, and hopefully this gives the listeners a little bit of an insight into when we use minimally invasive for trauma. So thank you very much, everyone.
Thank you.